Good evening, everyone. Welcome to the last session of the program. See how the time flies. And we are at the end of the last session. So today's topic of discussion is disclosure of medical error. I think that's one topic I kept for the end because usually we are not, very comfortable even talking about discussing or disclosing the medical error. Am I right or wrong? We don't want anything of that sort to happen, but then there are times when that happens, and then we have to, speak to the patient party and talk to our other stakeholders. And of course, it becomes quite challenging to uh, handle a situation like this. So, any one of you have had any training in disclosure of medical error? If you have attended any program? No, nobody? Okay. But has there been any chance where you had to disclose the error that happened at our end, done by us or by any one of our staff members? Ever? So errors do happen, there's no doubt about it. But then what happens when error happens? The focus is on hiding, covering it up. I agree. But then there are errors that neither can be hidden nor can be, covered up, and you have to come out. Actually, honestly, legally, we are supposed to be informing the patient party, even if it is a near miss. Even that has to be, informed to the patient. Even it did not cause any harm, but we are supposed to be informing the patient and the family about whatever happened. But we know the reality. Uh, Mostly the focus is on avoiding to talk about it. And one of the reasons is because we don't know how to go about doing that. Now, for example, if you were in a flight, which was about to kind of had a near miss crash, and some passengers, including you, were slightly injured. So, what would you like to know, and from whom, and when? Would you like to know or not? I'm sure we all would want to know if something, even if there is little turbulence, we ask our aerosters, what is it? Why is there so much of turbulence? Is everything okay? Are we safe? So, but if it was something really very serious and actually people got hurt, I'm sure we all would want to know. And when would you want to know?
Immediately.
As early as possible. So maybe either we will immediately ask the aerosters or any crew member to explain to us what exactly has happened. Or even if we don't get to know, the moment we land, we want to know from the captain, from the senior staff, what exactly was it? Why did that happen? I mean, is this a routine thing? Was it something serious? So similarly, I think patient and their family members, they are quite vigilant about what is happening with the patient. Any slight change in the patient's condition, especially if it is during the procedure, after medication, or after some action that has been taken for the patient, and in case something happens, they are able to sense there is something that is not being explained to us. So definitely they try to ask what exactly it is and why it happened. And a lot of time it is so obvious that there is no scope to hide or cover up or not discuss. So there the only option is we have to talk to the family and explain them what exactly happened. So any experience where you had to do this because actually something happened which the family could clearly see, for example, some medication error which they could see, or some identification failure? Anybody? if you wish to share your experience.
Yes, ma'am. Ma'am, in ICU, definitely the errors happen, and even uh, single medication, there are 34 opportunities to get it error. So if one will say no, there is no error in my hospital or in ICU, either you are bad. Say
Yeah,
the errors are of different kinds. It is of no harm, and if there is any harm happened, but it is that one can rectify it, or so you have just rectified before it happening,
mm,
so that is okay. But once the harm has or nature or scene
mm,
comes up to the extent,
yeah.
so you have
Means
this
there is no there's definitely.
recognition.
So any incident that you would like to share, Dr. Pradeep, where actually have something happened and you had to explain to the family?
Ma'am, error can happen, not medication, but I still remember one of my patient, the history of some altered sensorium. That fellow was a young adult, and
Mm,
initially we were thinking of some seizure because that fellow fell down on the wash basin. That was a history given to us.
Dr. Pradeep, I think there is
The
some
next
chat.
day, that patient was admitted to the ICU, and we thought it is just a post-ictal phase, but that patient developed full-blown severe.
Mm,
So the staff or staff didn't recognize that.
mm.
But luckily, when you came, then we and there all these embolectomy, this treatment, and luckily that patient
Survived.
off from that hospital.
Actually,
We have missed the diagnosis.
there is some network issue at your end, and that's where we are not actually able to clearly hear. I actually, honestly, I could not get much of what you were saying, but I believe that you are sharing some incident that happened in your institute. So, would somebody else like to share their experience if they have seen some kind of error, either by you or by any of your team member, or anywhere you saw, or it happened with you, your family member or relative, or any acquaintance?
Ma'am,
Yeah,
I have one.
sure.
I don't know if it's an error, but it's mostly because of communication, to be honest. Where we had a patient who had brought in, a patient and her husband. The
Mm,
patient was extremely unwell, and they were not willing to come into the hospice. So over the phone, for the course of almost a week, they were haggling with the doctor saying,
mm,
we won't get admitted yet. She's not that sick. But
mm,
unfortunately, what had happened is she got admitted. She was extremely dehydrated, and we knew she was in end of life. But when he brought her in, he was obviously bargaining still. Like he was still not
mm,
willing to accept that she was going to die. And for our, bad luck, she barely survived till the next morning.
mm,
She passed away at the night. So in the morning when I came in, he said, "Oh, the people here are killing patients.
mm,
She was fine all these days. How is that she died, suddenly?" And I said, "We've been talking and we know she's been deteriorating." He said, "I'm not telling you anything specifically because I had spent the
mm,
almost a whole week talking to him. I've spent the whole of the previous day discussing and having a family meeting." So he was saying, "This is not directed at you, but I'm very curious about how your nurses are trained in communication."
mm,
So there was a lot of angst and irritability. And he said, she's going to be fine. She's in her own transition. But
mm,
what I have to deal with is the fact that did I make a mistake
mm.
bringing her here? So I think that, that was something that I
A
thought
lot
I
of
should
time when
share.
things happen this way, they feel very,
Associate,
yeah,
yes.
yeah, even wrong, associations they make with the incident. Absolutely. So, Maheshwari, any incident that you wish to share from your uh, hospital or maybe wherever you have seen it, not your hospital?
No, ma'am, I haven't experienced this side.
Okay, great. I know it's not, I mean, usually, the challenge is most of the times people cover up the mistakes, or they think if we have been able to rectify it, what is the need to bring it to everybody's knowledge? So today, I think we are going to go deep into, first of all, and we're not going into why errors happen. We have been talking about that. But then when it comes to disclosing what are the challenges, why people are not comfortable, and in case if you have to do, what is the way to do it? And then we'll also have a look at one of these studies. There are multiple studies, if you look in, on Google, that support that when you disclose error, you actually are able to handle it more amicably. But then usually there's a lot of fear and anxiety about sharing. So we'll talk about all those things. So let me quickly share the presentation and then simultaneously have discussion with all of you. So I'm going to just share a couple of cases that I'm sure you must have seen or must have seen or heard of. Besides what I'm sharing, there will be a lot many more that you must have noted. So this is one case. It happened in Delhi. It was in news also. This patient was admitted to the state-run trauma center with head injury after a car accident. So he was mistaken for another patient who had a broken leg and who had to undergo surgery to repair the fracture. So this patient was picked up instead of the actual patient. And then when they started the surgery, they realized that, oh, they were about to operate on a wrong patient. This is again another case. This was also in news that two doctors, who were attending to this 51 years old physiotherapist. She came with, pain and then high blood pressure. There were some ECG changes also, but somehow they were not able to diagnose it on time. So there was a delay in diagnosis and treatment. And unfortunately, while even being in the hospital, she went into cardiac arrest and she died without any treatment, without any intervention. Another case where a 30 years old woman underwent a wrong procedure. She was there for just minor abdominal pain. Again, she was mistaken for another patient and who had to undergo dialysis. So they actually make arteriovenous shunt for this patient, and then they realize, oh, that's not the patient. So I'm sure you must have seen similar cases in your setup. I remember that case of Harjot Aluwalia. That was also in news, but that's an old case. Unfortunately, in that case, the child was being treated for malaria at another place. Then that child was brought to another nursing home, and the doctor diagnosed it typhoid. The child had to be given chlorophenicol. The child was unfortunately given chloroquine because earlier the child was getting chloroquine. So there was some misunderstanding. Maybe the sister or the nurse or the doctor. I mean, what exactly happened? If you look in Google, you'll get the complete case detail on Google. The child received chloroquine IV, and child went into cardiorespiratory arrest immediately. They resuscitated the child, but it was already a brain dead. Child led vegetative life, and that case was in news for quite some time. Uh, so these kind of errors, when they happen, I mean, of course, no error should be hidden, but then there is the scope to hide when you have such kind of cases in front of you. And we all know a lot of errors happen, whether we admit or not. This is an estimate by Professor Ashish Jha from Harvard University. He has estimated that 5.2 million medical errors happen annually in India. Honestly, if you ask me, I think we are underquoting it. There must be much more than that. And we also know that most of these errors are because of communication failure, identification failure. I mean, little more seriousness, little more protocol following. I think these errors can be prevented. So I think we'll do a small role play just to see how it feels to be there. So let's take that case one that we talked about, the first case, Rakesh Tyagi. So he was under your care, and he needed just suturing, but he was mistaken for another patient, and by your resident or staff nurses for repair of a fracture. And now you have already cut, but you have already pressed the patient's wound. the family has got to know. They got to see that there was no injury on the leg. How come the patient has come back with the, with the dressing? So, and of course, you have to now also talk to the family and explain them. So, if the case is clear, can I stop sharing and then we decide who will do? So, who would take the responsibility of?
Can I see the case once more, just for a second?
Give me 1 second. Yeah.
Thank you.
Okay. Let me stop sharing. Okay. So, anybody willing to be the doctor on duty? Okay, Dr. Pradeep, thank you. Because I'm sure some similar situation you must be handling day in, day out in your disease. So, who is ready to be the patient's attendant? Maybe, no? Dr. Pradeep, you don't want to be the doctor on duty? Please unmute and.
No.
So, what role do you want to play?
Ma'am, I didn't have that kind of situation in my life. That I was saying.
Okay, great. But let's see, I'm sure, but I mean.
Ma'am, doctor on duty.
Doctor on duty. Okay, great. So, any two persons who are willing to be the patient's relative? So, maybe we could take two daughters. Michelle, will you be? And Arshia? Okay. So let's see how Maheshwari, you and Shikha, I think still you are in cab, but without having your camera on, you can at least answer the question. So please observe how Dr. Pradeep handles the situation. Observe his body language, his tone of voice, selection of words, and how he really engages with the patient's party. So assume that Dr. Pradeep, you are calling them because you want to inform them. So surgery is done, the patient is back to the room, and now you are kind of informing the family. So you have called them to your room. Is that situation okay, Dr. Pradeep?
Yes, ma'am. Yes, ma'am. Okay.
So there is slight challenge. There is network issue on your side. So how will you manage? Let's see. Again, we lost the voice. Please unmute your device. Yeah. So I think Maheshwari and
There is a network issues definitely.
sorry, network issue.
There is network issues. There is a lagging of this your
Mm.
voice and image.
I can see that. So let's hope we are able to do this. So we'll both switch off our videos, Maheshwari and me, and then three of you can start the interaction.
Maybe we can, so ma'am, just one confirmation. So will the doctor on duty be already be there, or we go to his room and confirm, talk to him?
So assume that he has called you to your room, to his room.
Okay, fine.
Assume that either he has come to the patient's room where both of you are there. Dr. Pradeep, you can decide how you want to do it. So I mean,
I will call them to a room where we can sit.
okay,
That will be better option.
okay, go ahead. Yeah.
Uh, uh, Hello, I'm Dr. Pradeep. I'm, uh, I'm in a position of Deputy Medical Superintendent of this hospital. So I have to. Are you from Rakesh Tyagi family?
Yes, we are his sisters. That's Arshia, and my name is Michelle.
Yes. You are the. Okay. You are the sister of Rakesh Tyagi. He had some accident car accident. So he had one cut on the left arm, but I have to disclose one news to you that one of our resident and nurse, they had mistaken uh, um, they had given some uh, uh, wrong X-rays or CTs for which he had been operated on the leg.
How is that possible?
It is definitely a fault on our side. So
No, but I mean, he's
I
just had
admit
an
that.
accident, right?
Yeah, he had basically injury on the left arm,
Correct,
but
yes. But what are you trying to tell us right now?
I'm trying to tell you that there is one more patient near to him in the ICU, with whom his investigation and CT reports are exchanged because of the mistake of the resident and staff there. So he had been, while in the OT, he has been operated on the leg rather than on the forearm.
I
So
think
I'm
how,
extremely sorry
how
for
is that
that.
even possible? How is that even possible?
Yeah,
mean,
I mean,
Ma'am,
is
and
he
what
okay?
you mean that they, yeah,
no,
yeah, that,
he's okay. He's okay. He's doing well. I have met him in the post-op. He's doing well. He's fully conscious oriented, and the leg, all these things, he will be able to walk after 3-4 days. What the orthopedic surgeon has told me, but there is definitely fault on our side. I'm sorry for that.
doctor, what do you mean by sorry for that? I mean, he's already had an accident. He's already in trauma. You were treating him for the arm where we knew only the sutures have to be done. And now you're saying that, you've also operated upon his leg. I mean, how is that
Yes.
even possible? I mean, what kind of a hospital is this?
There
Uh,
is definitely
and
there is definitely a mistake on the surgical side,
can
even from the
understand the
ward.
mistake, but do you understand the kind of trauma the patient and the family will go through when this is, and how are you going to compensate for the mental trauma the patient is going to go through?
Yeah.
I can understand what you're saying. It's absolutely true, and we cannot compensate for that. What we can do, whatever the best now after this, uh, with other teams, that we can do.
See,
But
we were hoping that it's just a suture that needs to be done, and our patient will be discharged today. Now you're saying he
Correct.
cannot walk for 3 to 4 days. I
yeah, we
mean,
have to
And
we have
he's
to
so
keep.
young. I mean,
Yeah,
there's
we
no
have to.
need for him to have gone through something like this at this age, isn't it? Oh,
There is a.
this is. No, where is your doctor? I mean, I think we need to talk to him. Where is the person who did this? Like, who was the one who gave the orders?
No, we have suspended those fellows. We
No,
have
I don't think
suspended those fellows.
suspension is going to be the way out. Who's going to pay the bills for these things?
No,
And what
the,
is going to
no,
happen to our
no,
brother?
we will take care of bills, but we can't pay
the
for that. What
doctor.
you people are feeling mentally, and how what is going on in your mind. We can't compensate for that,
So,
and
so
bill
if
and
there
that
are
part
any
will be
post-op
taken care of.
complications, if there are any post-op or complications for a procedure like that. So what you mean is that you opened his leg and then you realize it's not fractured. I hope you did not even do something with the bone as well.
I will arrange a meeting with the orthopedic surgeons, with the family. They will explain you better. But what I
But
have
has this
come to
been
know it.
told to him? Does he
Pardon?
know this has happened to him?
Yeah, because he's fully conscious oriented, so he knows.
But why would you disclose something like this to him when he's just come out of surgery? I mean, he's already
The-
traumatized after an accident.
no, no. Excuse me, but he's fully awake, so he knows there is a bandage, there is a dressings all na, on his leg rather than on his forearm.
Oh my
Actually,
God,
this is complete negligence. I think we should take it to the court and take this
yeah,
hospital to
this
the court.
is,
They even think about it, do something like this.
Ma'am,
without.
you can take or no, it's
I think we should
you
take a
can take to
legal
the
action
court, but
against you.
our priority will be that first of all, what the harm has been happened that can be rectified and to be minimized for the best interest of the patient.
See, you're telling
So
us this harm because this is something that we can see now, right? You have bandaged the leg and we can see what is happening. We were in any case going to question you about this. I mean, if it was something else, then you might not have even, I mean, if this is the kind of negligence that takes place in this hospital, I mean, I will never recommend anybody to come to this hospital. This is the heights of negligence. How can this even happen to a patient who has had so much of trauma already?
you're absolutely right. You're absolutely right. What you're saying, but it is the first incidence for us also. So
I
That
mean, that's
I
pretty much our
understand.
bad luck then.
no, it could be destiny. I can
No,
say.
I think we need to talk to the doctor and the nurse, whoever was in charge, because they made us run around so many times, get the scans from down, make sure that everything is matching, and only then you went in
I mean, do you have in
for
the
the surgery.
in your
Yeah.
surgery operating room, do not have a checklist or a task list or, the checklist that tells you if it
Correct.
really is the right patient, if it's not the right patient, did you not ask the name of the patient? I mean, there is a
And his leg would have looked
protocol in
fine.
a hospital. How can this error even happen? I
Correct.
mean, this means there is a big,
Ma'am,
No, I
that's
think we
what
should call the
in the
doctor who was
hospital,
in
the
charge.
OT.
that's what I'm saying. We have
No, no,
suspended
no,
the whole team.
no, I don't think the
The
suspension is going to
we are
get them away
to
from
them
this.
No, no, no.
where the lapse
We need
has
to
been.
No, no, no. I
Uh,
think you need to
please
call
call your
whoever else
higher
is there.
management. We need to
Yeah,
talk about this to them. See, it's a
correct.
small thing that you feel, okay, fine, we've just operated the leg. If suppose, they'd operated the head like that, what would
Yeah,
have happened? If
no, no.
somebody had, then these cases have
I
happened.
think we should
That
call
people
home
have
and
operated
tell.
the wrong side of the
Yeah,
head also when they are treating something. I mean, if this starts happening in the hospitals near us, I'm very sorry. I mean, this is really a very, very sorry thing.
this,
And,
yeah,
we really need to raise it further.
this is
We have,
clearly negligence. I mean, come on. I mean, we are so
ma'am,
careful. You
I
made us
agree. I agree to
responsible
both
for
of
him.
you. I agree both of you. It's case of negligence. That's what I'm saying from the big suspended.
so what are the steps are you going
Correct.
to, implement
We will
to
take
ensure
action.
that these kind of
Whatever punitive
we
action
would
has
like
been
to know
to
what
be
steps
taken
are
against
you
them.
taking. We would like to know what kind of
The
steps you're
but now our can be patient
see for us. I think for our
to
patients,
recover as fast as to his normal life. So
and we would also like to have compensation for the mental
Yeah.
trauma and the trauma that the patient has gone through
No,
due to this surgery that
I
you've
think we should
caused.
put this
ma'am,
up in the
we
media.
will.
I mean, this is not okay.
I will ask the administration for that also. That will take care of definitely. The monetary part we will take care of. But what we can do is extra in hospital. Or, so that we can't compensate. But monetary part, what say we will go for that.
No, we are not going to pay, and I don't think we are going to pay even if it is for anything else related to his case.
Actually, he's saying
This
that
is
the hospital is going to take care of all the expenses. So I think, it's
everything. I'm
We
hoping
will
not
we will
just
take
this
take care of
surgery,
that.
but everything.
Financial, yeah. Financial aspect we will take care of. Financial aspect we will take care of. But what
Dr. Pradeep, it's not just about the financial
Yeah.
this thing.
best
For
we
us
can do
as
for this,
patients,
we will.
for us as patients, caregivers,
Correct.
and also as some citizens, I mean, this is a big, big negligence. We would like to know what actions your
So
hospital takes
Correct.
to ensure that this does not
we
ever
will we will
Happen
share
to
happen
with
anyone.
you.
again. We would like to have a
We will
complete
share.
report on that. We would like to have the real reasons why this
We
happened.
have to
How
the other unit
it
that is
happened.
taken care of this patient.
Sure. I mean, yeah, and I think we
We have
understand what
transferred
you're
this patient
saying.
to the other unit. They are taking care of it.
Sure. Sorry,
But
Dr.
one thing I will tell you that he's fully fine. He's fully conscious oriented.
Wonderful.
He's doing well. So
Sure. Okay.
Thanks.
Thank you.
Sorry,
Thank
Dr.
you.
Pradeep.
Yes, thanks.
it is my it's my first incident. We will take care of that. That's where the surgical safety checklist is important. It is the WHO safety surgical safety checklist in which the site has to be determined. It's a pre-operatively and in the OT also. But there is one case in the max Shalimar, if I'm not a Max or Fortis somewhere, where the calcaneum was operated. That was a hairline fracture.
I know.
So hairline fractures are easy to miss. So once
Yeah.
you see on the X-ray, hairline, you can't recognize. The bone seems to be united. So
Yeah.
there, in the prone position, the orthopedic surgeon put a nail, a screw in the other leg. So in that case, orthopedic surgeons were suspended or some license was cancelled.
True. I agree.
So
So, what do you think, Dr. Pradeep, you did effectively? I mean, you did a lot of good things, but what all do you think you did that you think worked for you?
ma'am, first of all, admitting the error. We should not argue with the patient. We must tell the patient the truth that this thing has happened. We are taking care of the patient. We will take care of the patient, and so
What else? One is, of course, you took the responsibility. You admitted that yes, error has happened. So that's one good way to honestly accept that yes, there is an error at our end. Because most of the times we bargain even on that. We don't agree that there is an error, or we say it wasn't an error. It can happen like this, and no harm has happened. So I mean, there's so much of chaos, so there's a possibility. So when you talk like this, definitely they are not going to be happy with this kind of explanation. So coming out openly and honestly, yes, there is an error, disarms them in a way that they can't now say that you are not even accepting is an error. Good. What do you think, Michelle and Ashia, Dr. Pradeep did well that helped you to calm down or to control yourself?
I think his tone of voice was great. Through it, like there was no major fluctuations, even though we were pretty much after a point, talking into his sentences. And I think he kind of agreed to waive off the bills pretty easily. So
Mm.
there was no
In
questioning back and forth.
reality, Michelle, in reality, does it really happen?
I was going to ask that, whether that is going to be something that, I mean, what are
Will
the consequences of it to the physician or the healthcare professional, right, for making that statement? Yeah, and
doubt
I
it.
mean, yeah.
They would, easily waive off the bill. Only thing is they'll say yes, error has happened, but then even I mean now of course things are changing because I know there's a lot of violence. Earlier, even for the corrective procedure or for some, for readmission, for re-procedure, even that patient had to pay. I mean, I've seen cases where patients were made to pay, even if patient had to undergo for second surgery or some other procedure because of some complication or error that happened at here. For example, you move the patient to another care center, and there they have to pay. Here also they have to pay, and they have to pay to the next setup also. I'm sure you must have seen such cases. So, Arshia, what do you think Dr. Pradeep did effective that worked in his favor?
I think, I mean, like Michelle said, one of us is, he accepted and he accepted that there was an error. And of course, then he also agreed to the compensation that would be given, or, the waive off of the money, which is, which is a must actually, which is a must if a patient has gone through such an error. But at the same time, I mean, I have had a personal experience with, something like this. I've got compensation for what went wrong with me, but it doesn't suffice, unless you see, has there been a change in the whole process? Will this ever happen with the patient again? The trauma that you went through, and you look for me, seeing the action, if I was the patient or a caregiver, also seeing what action the hospital takes eventually would be more important, after, of course, the compensation and everything, because the trauma for the patient. But here, as we see, because the error was not something which is a sentinel or, something which really will impact the patient.
It did not
It was
harm.
just a cut.
Yeah.
It was probably just a cut, and they came to know, it's not the correct way to, I mean, this is not the correct patient. But from, I mean, Dr. Pradeep's this thing, yeah, I think accepting the error and also, being in the same tone, not being aggressive with the caregivers and arguing too much and saying that all that is important. Unless that happens,
That worked for him. That's why you could not become aggressive with him.
yes,
He wasn't resisting anything. He was just agreeing to it.
yes.
So, Maheshwari, what is your observation in the whole role play? What do you think Dr. Pradeep did effectively?
Yeah, ma'am. Dr. Pradeep had gathered all the facts initially when he's going to start the conversation. He had all the necessary information and what had went wrong and what are the steps he's going to take it next. So he was ready with all that and he was so calm and composed throughout the conversation. And he didn't interrupt when the patients were aggressive or talking. I mean, they were like continuously accusing him that they won't be paying the other bills also. He was the rest of his treatment is to be taken care by doctor. In that way also he was so calm and pretty honest in his when he's going to accepted the error, and he was very honest and transparent in that way. And he was ready to, I mean, he expressed his empathy, I mean, putting them in their shoes, and he explained all the things. In that way, he was very clear, ma'am, how what he's going to say, and he didn't shift the blame on others. Like he was like, he took the accountability. Though the other person were there, I mean, he was telling that that person is terminated, who were responsible for this issue, and but he took the accountability and he was answering with the patient, and it was nice. Yeah.
Thank you. Thank you. So I think Dr. Pradeep, you did a lot of good things. Like for example, you introduced yourself, you took their introduction also, you checked for their relationship. Then of course, you started with saying sorry that something has happened and we are sorry for that and we take the responsibility. We accepted the mistake. You did tell that, I mean, thankfully, no harm has happened to the patient, but of course, the trauma that you and your family have gone through, I can understand that. Couple of things. Acha, okay, I want to ask you now. Given a chance to do this role play once again, anything you will do differently?
Ma'am, I have a question. Do they have to record the conversation what they're having with the patients? Or any doctor?
Usually, these counseling sessions should be done under CCTV recording, and it should be informed also to the patient party. So this whole conversation is being recorded for any usually, but it should preferably, because that helps you to, show as an evidence later on whatever you do. So, Dr. Pradeep, anything you would like to do differently given a chance? For example, you did and then you felt, no, I could have done it this way, as an afterthought. Okay. So, a couple of things that anything from your side, Arshia, Michelle, or Maheshwari, that you would want to tell to Dr. Pradeep? I mean, this thing could have been done in this way. Maybe it would have a different impact. Anything that you wish to?
So, I think from my point of view, if a patient has understanding, has health literacy. For example, I knew there should be surgical checklists. This is how it is done. Usually a protocol that should be followed. So maybe, if he had introduced that as well, then usually this is the protocol that we follow. And this was done or this was not done or whatever. I mean, for example, something was missed because there was an urgency to do this thing. But of course, in this case, there was no urgency. It was not such a big issue.
Maybe too much of that part cannot be brought in here unless they ask for it. Don't you have a system where you make sure that the patient is identified before you operate? So there maybe you can give as an explanation, no, we have a surgical safety checklist that we follow. But incidentally, 2 patients came in, but their files got exchanged. The case files got exchanged, and then that, of course, that can be given as an explanation later. But otherwise, I think most of the things were fine. Couple of things that I want to ask you. Yes, Michelle, you want to say?
Sorry.
Yeah.
So I was hoping that when we first got in, if he had asked us, or he would have told us like some signposting about that okay, I've called you in, for this reason, and you must be wondering why I'm talking to you. Maybe some background of asking us, what was your patient admitted for, what surgery was he thinking, and then probably like ease us into that conversation, because I felt like it came very directly. And I mean, for the first half, I think you saw both of us were not talking. Because there's so much shock, right? Like you can't even believe something like this has happened. So I would have liked some perception of understanding, like what do we already know, and because it's an
But
accident.
he started very well by saying that he had injury on the arm and he needed to be
correct.
sutured.
Yeah.
But then incidentally, this and he did try to, bring
that
it
in,
more to the yeah. But I understand, because for family it would come as a shock.
Sure.
It will definitely come. So my first question here to all of you is, he said that I am deputy medical superintendent. So would you prefer to know this from the deputy medical superintendent or the surgeon who operated your brother?
Surgeon?
So if it was surgeon and deputy medical superintendent, it was okay. But where is the surgeon? Who is the person who did it? Why are you telling me all this? He should have come and told me. Will that not be your reaction? Because you want to hear it from the horse's mouth. And the moment that person hasn't come in front, that means he's trying to escape. That means he's avoiding. He's not wanting to come and talk. So I think we need to check this. Should it not be the person who has actually done? Second is, I emphasized a lot of time, and I again remind you, know the patient, know the attendant. If the patient is under my care, patient is there for one day, I should know the primary caretaker. If I'm taking the patient for surgery, all the more important that I should know the family. If the patient is in ICU, all the more important that I should know the family. Why I'm saying this? Because when I talk to them and I say, Arshia, आप राकेश जी की बेटी है ना? ये आपके साथ कौन है? ये सर मिशेल है, ये आज ही आई है, ये मेरी छोटी बहन. That would really, even Michelle would become calmer, because she would assume that, okay, doctor already knows Arshia. That means they have already interacted a couple of times. That kind of calms down the person. So this one thing I always emphasize when you introduce, show that I know you. Arshia, you are Rakesh Tyagi's daughter, no? Or sister, or whatever. That would change the complete milieu of your place. That is one thing I will do. Now, mentioning that the error has happened by the resident or nurse, should we be mentioning, or can we just say that there has been an error on our side? Because the moment I will single out somebody, they would want to have a face on that name. A nurse by mistake did this. Who is that nurse? I want to see that nurse. I want to know from her, why did that happen? That's why it is always the system who takes responsibility. At our end, there has been no error. Unfortunately, this has happened by us. We have a tendency to fix the blame on one or two people. The risk is when you do something like this, now they want to have a face on that one or two people. Then the next question will be, call them here. बुलाइए उनको. इतनी बड़ी गलती कैसे हो सकती है? उनको दिखता नहीं है, नाम नहीं पढ़ते क्या वो? और आप कैसे डॉक्टर हैं, ऑपरेशन कर रहे हैं, देख नहीं रहे पेशेंट कौन है, आंखें बंद करके कर रहे हैं क्या? Because now they know whom should they be fighting. So we have to reconsider whether you should be saying like this कि डॉक्टर और नर्स से हुआ या हमसे. We, there's an error on our side. It becomes more like we take the responsibility. Of course, you took responsibility. You admitted that yes, there has been an error. And you also assured that he's okay, he's well, he's conscious, he's well oriented. Otherwise, he's fine, his vital signs are okay, he's doing well. That assurance, I think, did make them comfortable also, because they could see that not much harm has happened to the patient, but definitely an error has happened in our life. Then when it comes to bills, can I straight away say yes? Because the moment I'll say, "Oh, who will pay for these 3, 4 days?" That will be their first question. Second will be who will pay for this surgery? And for example, if it requires corrective surgery, at that moment we are under pressure, so we have a tendency to say, don't worry, we will look after the bill. The moment you will say this, then they'll say, okay, previous bill also need to be waived off. So there you'll have to learn to handle it very smartly. I'm not saying don't. Ideally, yes, whatever error we do, if the patient has undergone some procedure, corrective surgery should be done by us, or and we should not be charging the patient. But not that for all previous treatment, the patient will not pay. So that becomes kind of bargaining or blackmailing. Of course, there's no one-line answer to it. A lot of time we have to accept that under pressure. But if you immediately agree, then there's a possibility of further discounts and privileges they may ask you. So maybe at that moment you can say, for the bills, see, I understand. I'll definitely speak to my financial team and see how that can be sorted out. But right now, I think our focus is on the patient's welfare. When they talk about calling media, or maybe we want to file a case, medical negligence case, again, we have to learn to even handle that. So when you say something like, see, I can't stop you from, filing a case or reporting it to police. That's your right. You can definitely do. But I would say at this moment, let us work on making sure that your patient recovers faster. And if you will build that kind of pressure, the team will not be able to give their 100% to the patient's recovery. So I think that can be, you can consider it. I would say yes and no to it. But I would request at this moment, let's focus on patient's recovery. So automatically you are shifting their focus to the patient's welfare. So that way, rather than saying, no, इतनी बड़ी क्या बात होगी, आप पुलिस को क्यों बुला रहे हैं? पुलिस को बुला लेंगे तो क्या पेशेंट ठीक हो जाएगा क्या? है ना? ऑपरेशन तो हो चुके हैं, जो गलती हो चुकी है हम कह तो रहे हैं गलती हो गई है. That will be. So you have to handle these things. So when they say we'll call media, we'll call police, they'll say, okay, I'm going to call media. Again, calling media is not going to help us help your patient. At this moment, I would request that let's maintain peace and see what best can be done for you. So in this case, no harm has happened. There could be a case where actual harm happens. Then, again, you will have to bring the focus to the patient. Any questions about whatever we have discussed till now?
Ma'am, I have two questions. One was, what if this was the actual first time the physician was meeting the family? Because sometimes in accident cases, you might have very less time to process and do things. I mean, I have experience of that as well with my parents. So
I think that Dr. Pradeep did that in the right way, assuming that we are meeting for the first time. That I'm the one who operated you. But I would prefer it should be the surgeon who did the surgery should come and
Correct.
Because it looks like that the surgeon is avoiding us. And they
Correct.
also feel that it's such a big thing and he has just delegated somebody to go and talk to us. Why can't he come and give us first-hand information? So he should have come.
Yeah.
But definitely there are, especially in emergency medicine, we do see where the doctor may not have met the patient or family, but he is meeting for the first time.
Right.
Ji.
No, I just want to say that there could be altercation between the surgical team and the patient attendants. And there is a risk of that. So
Absolutely.
that's...
So maybe, okay, 1 second, I'll come back to your question. Michelle had one more question to ask.
The other thing is, should there have been a team meeting prior to this meeting with the family? Like, should there be some prep done before you go in? So for example, something like, are we going to waive off bills? Are we going to agree? Because these are possible things that are going to transpire from the conversation, right? So should there be like a small set of people who are meeting who are
It's always done. I think before you go and talk to the family, first of all, the management is informed. Collectively, they decide how they want to deal with it. And they would anticipate these kind of,
Correct.
expectations of the family, that they'll ask for bill, or they may become aggressive if they have already sensed some kind of, that muscle power, among the family, or their connection with the MLAs and some cult.
Political.
So they would already be in the know of it. And usually before they go and talk to the family, they would make that preparation in the background. It's always good also but then making any commitment at that point for
Correct.
waiving the bill or waiving of the bill or something, that should be avoided. That can be just put on hold, neither saying no nor saying yes. To say, see, I understand completely. You would not like to be burdened for the unnecessary financial burden. Let me speak to the management who manages the financial part, and can I come back to you about that in a day? But right now, I think our focus is on the patient's recovery and see what best can be done to minimize the damage. So, kind of parking the question. So, Dr. Pradeep, you were saying that family, yes, 110%, there's a possibility of argument and application. Why? Because they are unhappy. It comes as a shock. It's a bad news for the family. They were not anticipating something like this. So naturally, any harm, whether actual harm happened or not, nobody wants anything like this to happen. Having good rapport with the family, interacting with them as and when required before this happened. If you have been able to build good rapport and understanding and answering their questions and interacting with them formally and informally, that makes a kind of a ground for you that helps you to avoid that altercation. But definitely, in spite of that, there can be altercation. In that situation, also, your calmness, your expression of empathy, your willingness to take responsibility, your apology, and sincere apology. And at that point, asking, what do you want? What are you expecting from us? Tell us, please. That would give you a clear answer from the patient. So we have to, and you must have seen a lot of people, they are excellent at handling such situations. They immediately bring calmness and serenity. They would segregate the person, fall to three close family members of the patient. They'll take them to side room, talk to them, listen to them, understand their plight, and then they explain them. And then that's how they, So what I can do, maybe Arshia and Dr. Pradeep, you be the patient's attendant now. And bring up all these things, be it media, be it police, be it asking for money, be it being aggressive. And let's see how I handle. Do you think that would help us?
Sure.
Should we do this? Should we do this demo? Okay, great. So can I request Ashya and Maheshwari to? So I'm assuming that I am coming to your room because the patient is in ICU and I am coming to the room where both of you are waiting for the patient. Is that okay? Okay. And I'm assuming that I have not met you because the patient had come in emergency and the patient was taken to the OT, emergency OT. So incidentally, I didn't have a chance to speak to both of you. Is this how you want me to go ahead? What would you prefer? Anything. Okay. Hello. I am Dr. Indu Arneja, and I am the one who was operating your brother. So you both are related to Rakesh Tyagi. Can you tell me your relationship with him?
I am his sister.
Okay. Okay. What's your good name, please?
I'm Arshia.
Ashi. Achha. And sir, you are related to Mr. Tyagi? So, Dr. Pradeep, can you unmute your device because yeah. So, sir, how are you related to Mr. Tyagi?
No. I'm his elder brother.
So, as I told that I am the one who operated your brother. So, I have some important information to share with you. Shall we sit down and discuss?
I hope
Sure.
he's fine.
Yeah. Everything is fine, but there is something that has happened at our end, and I need to be informing you about that development. So, as you must have seen, your brother had an injury on the left arm that required suturing. So, when we were taking him in the OT, by mistake, case file of two patients got mixed up. So, his case file got mixed up with another patient who actually had fracture too. And uh, incidentally, your brother was taken to the OT for the surgery for the repair of the fracture. And after the incision, when the doctor tried to see where the fracture was and was not able to locate, then that is where they realized that this patient's case file had got exchanged with another patient. So we immediately, sutured the site, closed the wound, and we dressed up that area. And of course, then we realized that it was another patient who needed suturing of the wound on the arm. We have sutured that, but then when you will go to see him, you will be able to see dressing on his right leg also. So I thought it was my duty to come and inform you that there has been an
What
error.
happened? I mean, at your hospital, I don't get it. You had to suture the arm, but you sutured the leg. You incised the leg and sutured the leg. Do you even understand what kind of trauma, our patient would have gone through he had come for suturing, getting a small injury sutured, and you incised his leg and sutured his leg. How is that even possible? I mean, I understand you're coming here and telling me that there's an error from your side, but I don't get it. I mean, do you understand the kind of recovery time it will take for him to get out of this?
Akshay, I'm extremely sorry. I know this error has
There's nothing to be sorry about it. How can you be even, coming and telling us all this? I mean, there's nothing to be sorry about. What are we going to do with this?
I completely
ऐसे
understand.
मतलब वो भी कैसे सकता है? How is it even possible कि आपके हॉस्पिटल में जो इतना बड़ा हॉस्पिटल है, we come to this hospital because I mean it is one of the best hospitals. That's what we hear. You have NABH certifications, this and that, and you are saying that the files got exchanged and you operated a different patient. I don't get it. I'm very sorry, but I don't get it. This is not acceptable at all from a hospital like this.
I completely understand your anger, and it is very justified because nobody expects an error of this kind. But unfortunately, it happened because of the mixing of two case files. The patients are being moved to
But you see, thousands of patients day in and day out. If you're mixing every day files like this, I don't know what kind of errors are happening in your hospital. I think this needs to be reported. I mean, my patient is not safe. No patient could be safe here. I
So,
don't get it.
definitely, this is not going to be taken lightly. We are going to take serious, review of it. and we will
Before that, can you please tell me how my brother is? Is he fine now? Is he recovering? What would happen if there is a post-operative infection that he goes through? You're saying that you from top to bottom you have done an incision from top to bottom on his leg.
So, Ashia, thankfully, he's fine. It was superficial cut before actually we could do anything with the bone. When we didn't see the fracture, that's when we got suspicious that there is some error at our end, and we immediately tried to look for the details. And then we realized that this case file was of another patient. and there was an identification failure at our end.
How much time will he take to recover from this?
So otherwise, he's conscious, he's awake. He's, I spoke to him just now. He's well. After speaking to me, I would request you to go and see him so that you are also kind of,
That's
know.
okay. See, conscious and everything is fine, but you're saying that you made a complete incision. And so my question is, how much time is it going to for him to recover completely and walk and be on his own like he was before?
See, we haven't done anything to the bone. We haven't done anything to the bone. It was a cut on the skin, and then we realized that there wasn't any fracture, there wasn't any injury, and that's immediately.
Doctor, I'm asking the ETA for his complete recovery.
So maybe a week's time till the sutures are removed.
I mean, I don't get it. We were here just for a suture, which would have, there was no fracture, nothing on his arm. But now you're saying it will take him a week's time to recover from the leg mistake that you have done with him.
Asha,
I think we-
he doesn't have to stay in the hospital. We have sutured and we have pressed up the wound, and he has to come for follow-up after 1 week. Then we will be removing the sutures. He will be able to, like, after a week's time, he should be doing well. In any case, like for the arms also, he's going to
get it. I don't get this at all. I don't know how this error could happen.
Us-
Ji.
Yeah, I don't want to ask. You told it is fine, and I'm blah blah blah. The thing is that we compensate for his 7 days off from duty. Will be happen to the scar which he will have rest of the life. So will be play and about the bill of the hospital we have to pay for.
So for the surgery done on his arm, on his leg, I mean, because he didn't require it, so definitely there's no payment to be made for that. But whatever treatment has been done for him, that can be reconsidered. I'll definitely speak to my management. Right now, I'm not in position to give you an answer for that because I've not spoken to them. But that can always be discussed, But right now, I think what I would suggest, please go and have a look at him, talk to him, interact with him so that he also feels comfortable. He was actually inquiring, and I had to tell him that this has happened because even he was quite a kind of surprised when he saw dressing on his leg. And then I had to tell him that this error has happened at our end. But it
It's
will
not just dressing, no, it is not just dressing. He must be having such an acute pain with the whole complete incision of his. I hope your hospital understands that, and I hope you have that kind of sensitivity for patients. You understand you've caused. I mean, one accident he's had outside, one accident he's had in your hospital. I mean, I think your hospital should be closed with these kind of errors. What kind of system do you have? I mean, we would like to, and you were the person who did the surgery, right? I mean, what were you doing? Were you sleeping at that time or something when the patient was brought in?
I'm extremely sorry. I understand your anger, against me and against what has happened to your brother. And I wouldn't be justifying by saying that somebody else gave me the case sheet, somebody else put the patient, because it's my responsibility to make sure that I'm operating on the right patient. But this has happened, and I'm accepting the mistake. But at the same time, I can assure you that he's doing well. Go and see him, meet him, so that he also feels good. And in case if there's any, I mean, whatever, I would rather ask you what do you want me to do to make you comfortable and to make him comfortable. And once his sutures are off, I think he will be able to walk around comfortably.
I don't get it at all. I think we need to raise it to your higher authorities. Please give us the we would like to talk to your management. I think you're not fit to be working in this hospital itself. This is the kind of error that you are doing with patients. And I mean, do you have no protocol in your hospital? How is this even possible?
See, usually if any error happens, we always, go back to the start from where from where this error happened, and we take corrective actions to make sure that we don't make mistakes, in future. Definitely on this case also, there will be an incident review, and then we will be kind of doing, preventive action, root cause analysis, so that we see where we went wrong. Of course, even we don't want any patient to be harmed under us.
We want to be compensated fully for the harm that you've caused to our patient. You've got to, I mean, I don't know, you were saying that you've not talked about it. I'm sure you would have talked about it, and it's not that a simple thing. You would have expected this. So I would like you to meet the, higher management. This kind of error is not
So,
acceptable from a hospital.
I will definitely make sure that you are able to see my management. But at this moment, can I request you to go and see your brother, because I think that's most important right now, for him to feel good seeing both of you, and for you also to see him, doing fine. Is that okay if I request you to go and see your brother?
Of course, we will go and see him, but we're not even able to come out of the shock that you have given us.
I completely understand. I completely. Thank you. Can I expect everyone to come in? That's okay. Quite genuine anger. Anybody would be upset with that. So, Michelle and no, first of all, I think I'd ask Dr. Pradeep and Ashia, what do you think I did differently that you think worked for me?
I think for me, what worked was you were again and again saying, go and see your patient first, go and see your patient first. So for me, it was, somewhere going back to the, it showed that first it's important to see the patient. It also kind of, would have disconnected us from you for a while, so that, we could calm ourselves down and go somewhere else and, actually look at the whole situation, how bad it is.
So maybe after you saw your brother, doing well, I mean, you would actually realize, ठीक है, बाजू पे भी तो sutures है ना, ये भी तो ठीक होने में हफ्ता लगेगा ना, इसके साथ साथ वो भी ठीक हो, जब आप इसके लिए आओगे तो वो भी निकल जाएंगे. But then I can't say this. I never said this, because when you said for 7 days, then he will be, will not be able to do. I never said this. For his arm also, he's going to be sitting at home for 1 week. He's not going to go anywhere. But I just said that, like, whenever next we'll come for future removal, I think we should be able to walk comfortably. Anything else you think, Dr. Pradeep, anything that you think I did that worked for me?
Ma'am, I agree with Asha that you are telling us that go and see your patient, that patient is fine. That is disconnecting the whole process of conflict. And you are facing yourself the situation that, and the patient attendants. So that's a different from the earlier one.
Thank you. So, Michelle, any observation that you wish to share with us?
Yeah, I think again, tone of the entire session was maintained, so there was no like up and down. Plus, I think you gave them enough time for them to vent. I think they were able to voice their opinions, their frustration, their irritability, and I think that was important because you showed that you were listening through nonverbal, even though, I mean, you were saying, I can't do this right now, but I'm going to come back to you. I don't have enough information. I'm going to come back to you. So I think it also helped for them to not take it out on you or displace their irritability directly on you. And like everybody mentioned, in terms of focuses on the patient, focuses on, us debating here is not going to be the only way to handle this, why don't you go and check in on him? And I particularly like, even in Dr. Pradeep's case, right, that telling them that you personally gone and seen the patient, checked on him and come, I think that is really powerful. I think that is something that shows involvement and investment, even though there's been an error. And I think that goes a long way in terms of giving this kind of information.
Thank you. Thank you. Maheshwari?
Ma'am, when you told her that you didn't touch the bone, the patient's bone was not touched or any mishandled or something, only the incision was only the derm level. I mean, only the skin has been cut. So in that way, in that line was very soothing to the attender, so that okay, nothing has been damaged. Instead of the sutures, arm sutures, the sutures is on the legs. That's it. Nothing gone into deeper level. In that understanding, that would have calmed them. Instead of I mean, you have touched the bone and you have started the procedure, and half of the procedure you realize that there's no fracture, and again you have come back to that's little difficult for the patients attenders to accept it. And this way, I think this one line had harmed them. Maybe for
There can be a situation when you have actually done some damage. We have had cases where a healthy kidney was removed instead of diseased kidney. We have had cases. So, I mean, of course, they're very unfortunate cases, but then you have to deal with that.
But is it accepted then?
Yeah, Alshia was saying that you are not fit to be here, you need to be checked out and you should be suspended. I mean, you can get to hear all these kind of comments from your patients. They are unhappy, they are dissatisfied, they are agitated, so they can talk like this to you.
But I would like to share something, ma'am. So I think this sharing and disclosure, especially by the person who has done the mistake themselves, I think this is very important. I mean, from my own experience, I can share. I think the more, the biggest trauma is that the doctors try to hide it first. And then when they were, when I investigated, I then threatened from them through the consumer forum and everything. Then they came out and said, and then even, they were not ready to agree that they have done it. They were trying to justify themselves,
And that hurts more.
That hurts more.
That further, upsets the other party.
Because I still have that after 2.5 years, I still have the problem. I still go through burning sensation in my mouth and everything. And every time that happens, that cycle starts again.
Yeah.
That they don't, even if they gave my money back, how does it really matter? I was not able to even got compensated for the
pain and trauma.
The pain that I'm going through. And to head it all, they're still having a thriving business, and they're probably doing the same again and again with other patients.
Yeah, agree.
Yeah, so
I hope this whole discussion gives you idea what various perspectives, clinician's perspective, the patient's perspective, family's perspective, and how even management struggles with it, because nobody is very confident to deal with it. They just try their hand. Sometimes it works, sometimes they fail. And usually it ends up into mob attack or legal hassle. So, but if we learn the right way of handling it, I think a lot of situations can be managed and can be de-escalated at the right time. But there's no one-line answer to do this or not to do this. So let's quickly go through the slides. Although good discussion has happened around the role play, but let's have a look at these slides and take the discussion further. Okay. So this case we have already discussed. This we have also discussed this. So we have talked about it. We even talked about observations. We have discussed this. Okay. Coming to definitions, I think it's very important to understand I think before that there was a slide, yeah. So I think disclosing medical error is not easy. This I think we understand completely. And that's why people are not ready to come out openly and accept that yes, an error has happened. Because we all know it involves embarrassment, then there can be aggressive reaction. And of course, there's always a fear of litigation, that I will be defamed or I will be, pulled up by court. So therefore, people try to just cover the error. We know this and we can't deny this fact. Now, let's understand what are different definitions and what exactly we mean by, each word that we use in patient care. So, for example, medical error. So when we say medical error, it is actually an error that has, happened where you either use the wrong plan or, you fail to complete an action. And it may or may not result in adverse outcome. So normally we think medical error is when actually some adverse outcome has happened. Whereas it could be, there is no adverse outcome, but even that is part of medical error. Whereas complication, when we say complication, it is something that can arise during the treatment, and it's well documented part and parcel of the treatment. So it's not an error from a person's side or anybody's side, but it is something that is part and parcel of the treatment. That is, there is a likelihood or possibility of something like this. Omission, when we, leave something, we miss to do something, which we normally call under neglect of duty. And then unanticipated outcome, when the result is significantly different from what you had anticipated. I'm giving these definitions because we'll be using them when we hold a discussion about. Now let's understand, how do patients define different things. So patient's definition of error is very broad. They would even include things that are non-preventable. Even poor quality service is, according to them, is an error. Even communication, poor communication is also an error according to them. Whereas according to healthcare professionals, the definition of error is very narrow. If there is any deviation from the accepted standard of care, then we say yes, that error has happened in care. When it comes to expectation of disclosure, patient and patient's family want complete disclosure, all errors, whether they caused harm or even if they are near misses. They want to know, even if it was a harmless kind of an error that happened in the patient. Whereas we know that we like to only share the error that has caused some significant harm to the patient. Now, patient's preference to disclosure is that they want everything to be told truthfully but compassionately. Whereas we prefer to give minimal disclosure, only what is required. And then also in a very, very matter of fact manner, very limited and just to the point. Now, when to do the conversation, patients would want immediately. Whereas we want to have all the facts. We want to know, like you said, any meeting before you meet the patient party, yes, because we want to first of all know the risk, the compensation, the complication, the outcome, everything you want to evaluate before you want to speak to them. Now, and also about apology. Patients expect apology in all circumstances. Whereas our concern is that if I apologize, then I become legally responsible for what is. So therefore, we don't want to apologize. We don't want to accept that it is an error. And we all know that a lot of time errors are presented as complication. Because we know when we say it's a complication, it becomes more like a cover for what has happened. Now, coming to what do patients expect? What do you think the patients expect? What do patients expect? Write in the chat box. I think that would get us more answers.
I think patients, yeah. I mean that honest disclosure and what will be the plan next, and how will the harm that has been caused will be mitigated, and also, I mean, how will the hospital or the doctors ensure that this does not happen again with anyone else? These 4 things.
What do others want to add to it? Michelle, Dr. Pradeep, would you like to add something?
Yeah, ma'am, I put this compensation, honesty, or
I'm not
truth
able to
telling.
get the chats. I don't know why, what has happened, why I'm not able to access the chats. What has happened? Okay, I can see. I can see some answers. Okay, clear plan of treatment. Okay, compensation, early recovery, honesty, and truth telling. Yes, and then transparency. Absolutely. So that means patients, I think, first of all, want to know that what exactly happened. And they also want us to accept that, yes, error has occurred. A lot of time we are kind of not ready to accept that the error has happened. So they, fight tooth and nail with us to make us accept that error actually happened. Then, of course, they want to know the details of what exactly happened. They want full disclosure, and anything if you try to hide or cover up, they would insist on knowing even that part. Then, how is that going to affect their health? Like, for example, Ashia was constantly asking what will be his recovery, will he be able to walk around, will it affect his health? So, what is going to be the impact of the error on the patient's life and future? Then, who is responsible for it? A lot of times they want to know who is responsible for it and then why it happened. How can that error happen? What exactly happened? Why did that error happen? And then, how will the reoccurrence be prevented? So how will you prevent this error from happening again? And then, of course, they want apology. So when it comes to desire or the admission that yes, disclosure should happen, you'll be surprised to know that 90% of the doctors support the principle of disclosure. They say that yes, we should disclose if there's an error, but only 30% of the doctors actually disclose. Because, as we have said, very few people are comfortable talking about any error. Now, studies suggest that almost two-thirds of the errors are not reported. At the same time, even if it happens, it never meets their expectations because it is not done in a very honest and transparent manner. And trainees, especially, if they haven't learned, so when they are practicing, definitely they will not be able to display that skill. By the way, why don't we disclose? What are the concerns that stop us from disclosing? You can write in the chat box if you're comfortable writing in the chat.
Management aspect?
Legal action, absolutely. That's one of the major reasons that one fears, yeah. Reputation, yeah. Because they know their reputation is going to be affected. People would talk ill about them or they may defame them. People might go and write poor reviews on Google. Medical legal case, yes, definitely, because they fear that there can be a legal case against them. Violence by patient, that's another concern. The family will become aggressive and they may start, they may lose control. Absolutely. So we fear that all these things can happen and therefore we don't like to disclose. I think one of the reasons is that, especially if the error hasn't harmed the patient, we really are skeptical about the benefit of sharing with the patient party. And we believe that the disclosure is unnecessary. We also think that it would cause unnecessary distress to the patient and family. Whatever had to be done, we have already done, especially if we have taken the corrective action. We think there is no need to inform the patient and family. Especially in case where the family is not or the patient is unlikely to find out, we think that there is no need to talk about it. Of course, there is a fear of retribution from both patient and the colleague. They will be talking poorly about us. Fear of legal action, like many of you mentioned, financial judgment, you may have to pay compensation. Then fear of having to handle patient's emotion. Most likely they become aggressive, they accuse, they talk poorly about us. So it becomes difficult to handle and also control your own emotion. There's also a belief that disclosure is primarily a factual conversation. So it's not a complex interpersonal conversation. So some people, they are not comfortable in getting into it, so they avoid that kind of a discussion. And of course, a lot of time we believe that the outcome is not related to the action, on the part of the person disclosing. It's not my fault. It was the nurse who did it. It was the doctor who did it. It's not my fault. So why should I be telling? And then, of course, because of the lack of training in error disclosure, people find it very difficult to actually. Now, I want to ask you, what are the benefits of disclosure? Is there any benefit of disclosure? What is the benefit? Are you writing in the chat box? Okay. I'm waiting to read. Yeah. Okay, self-satisfaction. Okay. Trust. That's build trust. When you are honest, they'll have trust. It shows more investment in patient care. Okay. That shows that you are concerned, invested. Absolutely. Ethical reason. Yes. Ethically, we are responsible to disclose. Taking responsibility. Yes, that's very important because especially where you can't deny, you will have to take responsibility. More you will try to deny, more problem you will be into. So studies have shown that if you disclose honestly, it actually helps you build trust and establishes communication with the patient party. Of course, patient safety gets ensured because one error identified and also shared with everyone will ensure that next time the same error does not happen. It's an ethical and legal obligation to inform the patient and the family. And of course, it would be continuous quality improvement because every time you report an error and you take corrective action and preventive action, all future errors get rectified or prevented. Studies have shown that if you disclose the error in a skillful manner, you're actually not only able to reduce the error that happen in future, you also reduce the risk of litigation. Only 3 to 5% of the patients actually sue the hospital or doctors for negligence. Most of them get satisfied by the explanation they receive from the treating doctor, and if their concerns are addressed or they are looked after well, most of them get satisfied with. Usually patients sue when the communication that is made to them is not appropriate or not enough. So whenever there is ineffective communication or there's lack of empathy, when we are insensitive to their plight and we are rude and aggressive with them, they feel being mistreated, and then also they perceive probably we are holding the essential information. But actually, it could be true that we are withholding the correct information. So at this point, I want to share a case study with you. This case study is from University of Michigan, where they actually implemented full disclosure policy in 2002. So they actually followed 3 components in the full disclosure. The first one was if the patient was harmed, they acknowledged and they compensated patients quickly and fairly because they felt if we have done a harm, we are responsible for the treatment that we need to provide to undo the harm. If they felt there was no error, even then if the patient tries to implicate them into any legal hassle, then they aggressively defend themselves in court. Because if they're very sure that no error has happened at our end, they will fight tooth and nail in the court so that they don't have to pay unnecessarily. And third is, if there's any adverse event or anything that has happened, but they feel that this should be, looked into and it should be made sure that we should avoid them happening in future. So they collected the data, and you'll be surprised to see that August 2001 and August 2005, after the implementation of full disclosure policy, their annual litigation cost actually went down by almost 2/3. Then the time also invested in resolution of these claims and lawsuits went down almost 50%. And even the number of claims of lawsuit got reduced almost like 50 to 60%. But I know it's not easy to implement. One really requires a lot of courage and vision and proper procedures to do it, but then in the time to come, I think this is something that we will have to really take very, very seriously. So I'm going to share you a couple of guidelines for disclosure of error, although most of it we have already discussed. So I'll quickly rush through the slides because I know we have talked about it at length in number of topics and also today also. So these guidelines are based on the recommendation of many prestigious organizations. You can design your own method of doing it. I think the first thing is make sure that you know everything about the patients, review all medical facts, check how you are feeling. Are you confident? Can you handle it? Can you talk to them? Because it's very important to, prepare yourself for the kind of exchange that's going to happen between you and the patient party. If you're scared, if you're upset, if you're agitated, if you're already annoyed, you are going to lose the battle. So it's very important to prepare yourself for something like this. So when it comes to actually sitting and talking to them, I think most important here is begin by stating that there has been an error. So don't beat around the bush and then come up with this, we were doing this, there were a lot of patients and there was a lot of rush and suddenly one patient fell down and we were looking after that patient and then your patient was put here. They don't want to hear all that. They want to hear what their concern is my patient okay? What exactly happened? Please tell me. So state by start with stating that there has been an error. Then, of course, you can tell how this error happened in a very, very simple and non-technical manner. And then state what is the nature of the mistake, what is the consequence, and what corrective action you have taken at your end. In between, frequently pause because they would want to ask questions, they would want to show their anger and resentment. Allow that to happen because ultimately they are upset and they want to take out their frustration. And usually you are the one who will have to really listen to the music because you are the one who were responsible. So allow them a chance to ask questions or say whatever they want to say, because that's where you will get to see on what lines are they thinking. If you allow them to ask a question and you answer their question, definitely that dialogue will help you to know on what lines are they thinking. As I've said, a lot of time, apology helps. Then the moment you agree that there has been an error, the moment you say, I'm sorry, this error has happened, it's very unfortunate. We take full care and responsibility, but a lot of time, in spite of or everything, things go wrong. And unfortunately, today was the day that something like this happened. So even when you are apologizing, rather than putting blame on others, take responsibility that we as collectively or I am responsible for what has happened. But do not accept fault unnecessarily if you haven't really gone wrong. So in between, invite questions. Do you have any questions about it? Do you want to know more about it? So you will get an idea what is going on in their mind. So make a follow plan. For example, if you have told everything, the patient is fine, patient is in ICU, he's under observation, he's getting, whatever needs to be done. But then you want to tell them, okay, I'm going to see the patient, or if you want, I can take you in and show you the patient. So that's like your follow plan with them. They will definitely ask you, how are you going to prevent future errors? How will you make sure that no other patient gets, affected like this? So that's where you will have to kind of explain what CAPA you are planning or you will do. And then, for example, they would want a next update. For example, patient is in ICU, you can't allow the patient party to go and see. Maybe the patient is in serious condition, or the doctors are still working on it, or maybe second surgery is being done. So that's where you have to tell them, see, I'm going back to the OT, we are working on the patient. Maybe in an hour's time, I'll ask somebody to come and update you, or I will come and update you. So you are also keeping them in the loop and telling them that what will be the next update, and make sure that you keep them informed and not make them. I remember there was recently a case in the news that a patient, I think, was taken for angiography and then angioplasty. And the whole thing went on for 13, 14 hours. And the family was not updated at all in those hours. This was the case in the news, I think I read it. So that actually kind of confuses them, and they would start assuming so many other things. Whatever it is, we have to inform them, whatever the situation is. In any case, they will get to know. So whatever has happened, it is important to document them. So make sure that you report the incident and the actions taken. So whatever corrective action or preventive action or action that you took, or clinical decision that you took, a reason for that clinical decision, and then what was the outcome and what do you intend to do, after this. Then of course the discussion you had with the patient and family, like whoever was present, their names and the relationship with the patient, and then of course whatever questions they put and the answers that they put. So brief report has to be, put in, of course, sign and date, and make sure your contact details are there on that. After everything is over, it's important to again sit and reflect, because that's where the real learning lies. So when you sit and kind of self-check in, how are you feeling? How are you feeling at that situation? What emotions were actually, you were experiencing? But what was the thought process? That will give you an opportunity to correct your reactions and responses in future. There's no harm discussing with your colleagues, because you get good ideas from your colleagues, how they handle, what advice do they give. That's why you saw every time we do a role play, I make you reflect on your performance. Then I ask others to give their input. First of all, feedback, what you have done well, what was done effectively. So that you get positive feedback. And then I ask you to reflect and say, is there anything that you want to do differently? And then I ask others also to give their feedback, anything that you think this person could have done. So the whole idea is that when we get input from others, we get to, see things more objectively and also get new solutions to the problem. Of course, we have to keep updating ourselves by reading the material and also attending the programs on crisis management, conflict management, aggressive behavior. These are the ways to, prepare yourself for situations like this. So just to quickly summarize what we have discussed, most important is prepare yourself before you actually go and do the disclosure of error. Straightway, simply explain or agree and accept that what has happened. Apologize, that would calm them down. At least tell them that, okay, that shows your compassion and empathy also when you apologize. Take responsibility, invite questions, let them speak, listen to them, and then make the follow plan together. Document and thank you. Okay. Any questions on? So Shikha, you're there.
Yes, ma'am. Ma'am,
Yes.
my question is this: if it's a very it's in the situation where the no harm actually happened to the patient except superficial. If the sentinel event has happened, if the cardiac arrest, or in those situations, should we do differently from these principles, or we have to follow this only?
See, these are just guidelines. You will have to assess the situation and think and, handle it, what you think will fit in that situation. But escaping the situation, avoiding the situation, not interacting with them, not letting them know anything is not giving. That's one of the reasons why we are losing trust. Why patients are not ready to trust us, because they feel that we are not honest and transparent. We have to see, if you build rapport, if you're able to demonstrate, I'm a responsible doctor, I'm not God, but I am responsible, I'm careful, I care for your patient, I'm working seriously for your case. And then if something goes wrong, usually they don't blame us for the outcome. The problem is we didn't make rapport, we didn't answer their concerns, we never treated them equal, we never shared what is happening, and then suddenly we say, oh, patient has died. Then naturally they will say that you made money and you failed me. So partially we are responsible for the losing trust. At least these protocols have to be followed. Right from the beginning, build rapport, address their concerns, ask them what they want to know, answer their questions time to time, keep updating them, discuss treatment options, let them decide, share decision making that we talk about, engage them in decision making, tell them the risks, informed consent taking. If you let them know the possibility of complication or risk or high risk, they will be mentally prepared for it. And then if something happens, you will have to come out and speak and talk to them. But usually, if you have done your homework well, even unfortunately, if that situation happens or comes, you will still be able to, manage it, because they will, by then, they have created familiarity with you. They are more acquainted to you. So they're less likely to be. What more questions you have? Others? Shikha, any question from your side?
No, ma'am. Apologies from my side only.
No problem. Were you really overhearing, or you were also like?
No,
And-
no, no. I'm only already in the class only.
You were listening. You were listening to the.
Yes, yes, I'm listening.
What do others say? Any question? Any feedback? Any comment? Michelle, Arshia, Maheshwari.
Mine is more of a question relating to how do you implement something like this in a setting where maybe it doesn't exist. Or talk to people about, like, who do you actually go in and talk about this with? Is it
See,
the medical
creating a
side?
culture of patient safety is very important. Training people to have difficult conversation is very important. Doing mock exercises is the way to make them comfortable. Supervising them, doing it, maybe at least, even small mistakes, when people start reporting either to the management or to the patient, that's the way we kind of bring, create that culture where people come out honestly. If we are in the same situation and we just focus on covering up, so we are setting an example that all said and done, you don't have to go and report. So it's a journey actually. Patient safety, quality implementation, these are all very slow processes, but you have to continuously work for it. So to start with, I always say, if you go and tell them that we must report all errors, nobody will agree with you. But if you tell them that we must prepare our staff that in case if an error happens and there is no way out other than, going and sharing, at least they should know how do I go and do that. So there probably their mindset will start changing that, okay, at least we should be prepared for it. We should know. So any question from Maheshwari or Ashya?
Only question, is that, how effective can it really be? I mean, when we are saying disclosure, I don't think near misses would be disclosed to the patients. They will always be avoided. And we see it practically also. I think this is, what anyhow, hospitals do not disclose even, big events, but if we see near misses or something that can easily be missed, that's a human this thing. But, so from what Michelle was sharing, there's a book called Book of Habit where I read a story on, and I can share that story with everyone. So I read a story about mining, a factory, an industry, mining industry, and it talked about that how this new CEO had come. And so mining industry is also one of the most dangerous industries, thought to be one of the most dangerous industries. However, though mining is more dangerous, healthcare industry is actually, more dangerous than mining. So this person, CEO, instead of talking about revenues, instead of talking about, how they have to increase their profits and everything, he said one thing that we have to set up in our factory is safety of our employees. That no safety incident will happen in this factory at all. And they made it a culture that any safety incidents, if they happen, they have to be reported internally. And, and it was mandated that an action would be taken. A kappa would be done and, these things would be done. So it was internal, everything was internal, but that culture changed. So initially, it was, people were asking, what is he even doing? Why should we even talk about it and all that stuff? But slowly when he mandated it, this culture started building in the company, and people started actually respecting and really wanting to, report these events so that those corrective actions could be taken, prevention should be done. And this particular company became one of the most profitable companies. And also the attrition rate lowered a lot. So, but the thing was that even if there was one person, so there's an incident where one person was a very senior person. He committed some, there was a safety incident that happened there. He did not report it. And when the CEO came to know about it, he, took him to charge and he was suspended or something like that. So, I mean, that kind of a real, if this change has to happen, those kind of actions, that kind of culture would need to be built to be able to.
So, Arshia, in hospitals now, they are creating this culture of patient safety and employee safety, safety culture. Let's call it safety culture. And they're actually rewarding people for reporting the error. That's now is the new trend. So things will change. Of course, it's a very slow change because there's always a fear of retribution. So people avoid accepting. But when we will stop reprimanding person who has made a mistake, and we will start awarding or rewarding the person for admitting that yes, error has happened, and this is what I'm reporting. So hopefully, in the time to come, things will change. But it's a very mixed kind of. It's not only in India. I was seeing this Netflix documentary on Boeing, Boeing 360 or what it is. See how they compromise the safety features of the Boeing, and back to back, I think two or three Boeings, actually Airbus, crashed. And there was a very in detail inquiry, and they could prove that there were safety lapses, and the focus was on making money and not, the safety of the, aircraft. And but see, even those developed countries, they get greedy and they get carried away with the vested interest. So imagine, India is still a developing country, but I hope that more awareness we create, more responsible we will become in our actions. We are on a journey. We have to understand that. Thank you. So, if there are no questions, I think Arshia has a presentation to make. So, should I allow you to share the screen, Arshia? Yeah, now you can share your screen if you want.
Can you see my screen? Okay, you're able to. Okay, so the topic that I will be taking care of today is use of videos in healthcare pedagogy. And let me just put in more. So the brief agenda is we'll talk about why use videos in presentations, how it helps, the do's and don'ts of using videos in teaching, and tips of effective video integration. So to start with, I would like to show you, a very small 1-minute video. Um, let's watch this together and we'll go further on it. Are you able to watch the video?
Did you know that falls are the leading cause of injury deaths among
Is audio? Are you able to hear the audio? What's from the video?
Hear the audio, but I'm not able to see the video. I don't know what that is.
One second, okay, just a second. The screen is not sharing.
Sometimes people may have problems remembering what they want to ask.
Are you able to see my screen now? Can you
Yeah,
see
now
the-
it is, yeah,
Okay, is it audible, ma'am?
yeah. I think you paused it, yeah, you played, then I think.
Okay, the video was also audible, right?
Yeah.
Okay, great.
Sometimes people may have problems remembering what they want to ask during a visit with their healthcare team. Here's a way to help you get the information you want. Try using Ask Me 3. What's my main problem? What do I need to do? Why is it important for me to do this? Ask Me 3 helps your provider and team give you the information to understand your condition and take care of yourself. Ask Me 3. What's my main problem? What do I need to do? Why is it important for me to do this? To learn more about your health and how to be involved in your healthcare, visit www.veteranshealthlibrary.org.
Actually, a different video played than what I had decided
Every
to
woman
play.
veteran has earned and
Just a
deserves
second.
the very best comprehensive health care. And VA understands and respects that when
Okay. Okay, can you see my presentation?
No, please share the screen.
Okay, so from the small video that we just saw just now, what do you think how videos help? Something, if this is something that I had told you or written to you and given you a document, yeah, or, I was showing a complete presentation. I was saying line by line, this is what needs to be done. This is what needs to be done. Would it be more effective? Or, a short video on how, actually what I wanted to show was this video on preventing falls. I think a different video played. And, this also played like this, that, how the falls can happen in different situations. So again, yeah, the question again, what do you think, how videos help? Anyone? Michelle?
Yeah, so I think it helps to like bring some clarity, right? Like, I mean, I know I'm a very visual learner, so for me, a video any day makes more sense than probably reading something, right? So definitely it helps me capture my attention and focus. And it's very crisp, so it just gives me what I need to take.
Great. Shikha, what do you think? Does video help you as well?
Yes, because pictures clicks the brain more prominently and it remains for long so that you can easily recognize the things well.
Yeah. Okay. What about you, Dr. Pradeep and Maheshwari? Would you like to share your thoughts?
I agree with the rest. That audiovisual impact is always better than the posters, definitely.
You can also relate with the topic. When you see the video, the understanding will be even more better than audio or any presentation. Yeah.
Yeah, I agree. Yeah, wonderful points shared, everyone. So, I mean, this video that I just showed was one kind of a video. There were, other videos in our classes also. Dr. Indu also showed, some videos where there were role plays and there were situations that were there, and they were as impactful because we could see, okay, what would have happened. So instead of a person telling the story of what could have happened, it's like a movie playing in front of you, and it also brings out the emotion, and you can understand that particular situation in a better manner than just listening to somebody from their mouth or, reading a story about it. So, as they say, a picture tells 1,000 words, is more than 1,000 words. It's also, videos become more powerful because it is then an audio visual medium. So, now, why do we use videos? And, some of these points you've already shared. First of all, videos, are very engaging. It can capture students' attention and keep them engaged. And if you take the example of children, I think they are most engaged with the videos than any other medium. And if we take, but not limiting to that, as adults as well. If there is a video, we, it's easier to, if there's a crisp video that gives us all the information, it's easier to understand it and understand the concept itself. Then there is visual learning. So as we know, like Michelle shared that she's a visual person. They can be, students who would understand it better only if they're shown a thing visually, if than any other medium. It enhances the memory retention and through visual and auditory stimuli. And finally, diverse kind of content can be shown through a video. It can be through an animation or real life examples, expert interviews can be there. So in many ways, you can use any kind of a video and one needs to select the right medium or the right kind of content to be able to share it for that particular topic. So now if we look at what are the do's for using videos in pedagogy. So it's important, like they say, when you're telling the story, you should always, know who your audience is and whether, the video that you are sharing, does it align with the objectives for the training that you're going to show. So it's important that we ensure that videos align with the learning objectives. Are there interactive elements? For example, have we incorporated quizzes or discussion? So like, for example, nowadays there are, certain interactive videos or, or if we go on TV, there are these interactive, so if you select one thing, it can change the reaction. So these are different ways that can be included to make the video or that content that you're sharing interactive. Then it has to be a quality content. It should be relevant. It should be up to date. Supplementary material. So once we've shown the video, it's not, just a standalone pedagogy content. When you have shared the video, it's important to build context and to really build on it, that how it is important and go from there. Then feedback, encourage feedback to understand the video's impact on learning. Now, what to avoid? And this is, I think, very, very important because, one can get very excited in sharing videos, but if you don't share it in the correct manner, it will lose its power. So, for example, overuse, avoid overlying on videos, balance with other teaching methods. And so, for example, you showed a video for the whole lecture, then, it can get very boring. Again, lengthy videos, it's very difficult to watch the lengthy video. So I can take example from my own organization. So usually we record, any trainings that are conducted, the live trainings that are conducted. But, recently what we have seen, if those trainings are just 20-minute modules, it's very easy to absorb them instead of looking, seeing a complete 1 hour or 1.5 hour training. So, that is something that can be done. Small modules can be created. Passive viewing, don't let students passively watch. It can be, for example, like I showed a small video and then I can engage with everyone, how it impacted you, what should be done. So all that. Then irrelevant content, again, it has to be relevant to what you're sharing. Technical issues, I think this is very important because, if you share a video, but it is buffering, it not only wastes the time, it also, is very frustrating for whoever is watching or whoever is listening. They lose interest in the complete lecture itself. So that's also important. Tips, how to ensure that what you are, if you're using videos, what should be kept in mind. So review your videos before. Don't just take it, okay, now. So for example, I did this mistake. Though it was not intentional. I had seen that video on Bing. It looked that it is the only one that will play. But after I pasted that link, I was not able to see the same video, something else played. So it's very important that we review the videos. We ensure that what is going to go in the lecture is correct. Contextualize, again, introduce the video and explain its relevance to the reason. Pause and discuss, that we already discussed. Closed captions, use captions to aid comprehension, support diverse learners. This is also very important. There can be learners who do not understand a particular language. So if we have captions or subtitles for them, that can really help them assist their learning as well. Follow-up activities, plan activities or discussions, post-reviewing to reinforce learning. Then finally, what to keep in mind. And as you know, ma'am also emphasized this in our trainings, that we have diverse preferences. I could be a visual, audio-visual learner. So it's important to know your audience well. Whether, if we have a diverse audience, and if you feel, there is a less of a particular kind of, learning preference, then we can accordingly adjust what kind of medium we are using for that. Copyright, it is important that whatever video we are using, if you're using it for commercial purposes, they should not be copyrighted. And if we are using them, then we are giving proper credits. Accessibility, make sure after the video has been shown, it is accessible to the students. Assessment, use videos as part of a broader assessment strategy. And finally, continuous improvement, regularly update and improve the video content based on the feedback that you receive from the viewers. Yeah, that's all from my side. Thank you so much. Any questions?
Thank you, Arshia. Any questions for Arshia?
No questions.
Thank you,
Everybody's
Arshia.
really tired after a long day.
I had one.
Yeah.
Are there probably situations where you will not use videos at all? Like in terms of training?
I think it would be, from case to case. I don't think there could be, like, for example, a simple situation could be if people, like I said, there's diverse learning styles. If you already know that this kind of audience will not have a utility of watching a video, and it can be avoided. But I would like Hindu ma'am to add on that.
Because I feel like it's quite a
Too
new.
large. Sorry, you should
It's
go.
no, it's quite a new thing, no? Maybe in the last 2 decades or so.
Yeah.
Teaching through
Video.
videos is something that has obviously gained popularity. So, are there situations where
So if it's too large an audience, then I think video may not be of much help, because only few who are sitting in front, they will be able to listen and watch. Others can get disengaged. That's, I think. Also, I think video selection has to be done very carefully. It should not be controversial. It should not trigger any kind of conflict or controversy in the group. And it should not target any particular belief or religion or system, because then again it can trigger conflict between people. So the selection of videos have to be done carefully. Also, we should not use video which are already seen by people. Then people will not have curiosity or interest. Of course, she has mentioned that it should be very well related to the topic. It should actually be very clear in terms of its message. And there has to be a message in the video. And of course, briefing and debriefing before the video and after the video is important. What is the takeaway? What is the and you get a lot of new perspectives also when you discuss about the video, because a lot of new things come up when you play a video. And especially for complex topics which are not very tangible and not easily explainable. Videos are a very powerful way to express and show them. For example, the assertive communication that we talked about. So 4 styles of communication I demonstrated using 4 different ways. So verbally I could have said this is passive aggressive, this is aggressive. But I think you could distinctly see in all 4 videos that in video in which I was aggressive and video in which I was assertive. So even empathy, that video on empathy, that also, otherwise explaining empathy verbally, you can do it, but experiencing it is very altogether a different experience. So videos are otherwise a very powerful, especially procedures, for example, when you want to show some procedure. Again, explaining verbally is not enough. Even if you draw and explain, that is not enough. But if you show them a video, they get an idea of what exactly is going to be done in the procedure. Even patient education using video is again a very powerful. Any other question or feedback to Arshia or to me, of course? So I will be posting a feedback form and post program assessment form in the group, because I know it's already 10:10. But can we spend 5 to 7 minutes getting your feedback? Because we are just 4 or 5 of you. If you can take out a minute or two, I'm sure you have written something that you want to share as your feedback and your takeaway from the program. That will be really nice. Michelle, can we start from you?
Sure, ma'am.
So introduce yourself, tell your name of the organization, what position you hold there, and what has been your learning.
Yeah. So I'm Michelle Norman, and I'm a psycho-oncologist. I work with the Bangalore Hospice Trust Karunashraya, which is in Bangalore. Firstly, I want to say thank you to ma'am, and it's been wonderful to be interacting with all of you as well. I think I have never had an opportunity to be trained in communication skills per se, even though in bits and pieces during my training in psycho-oncology and palliative care, we've had these sessions. And like I've mentioned earlier, because my PhD is looking at understanding end-of-life care related communication among healthcare professionals, I thought this was the best opportunity to do it. So a couple of things that I really enjoyed about the course was, one, it really made me introspect about what exactly is this communication skill training all about, right? What is it in for me? What is it in for the audience? And how individualizing each and every aspect or component, like prior. So planning it in advance is something that I feel going forward, I'm going to do it and not just, go with the same presentation that I would have for different audiences, right? I think also individualizing it based on the participants. And I think I was discussing this with ma'am as well, that last month I had an opportunity to do training in communication skills for nurses. And this is the first time I had literally like 10 slides. And it was full of activities, just like how ma'am would do in our classes. And it gave me an opportunity to actually help the participants reflect on their own communication skills. And I think that was extremely powerful, because at the end, when I concluded, one of the things that we did was, what is that one skill you're going to work on, when you leave this room today? And I have honestly never done something like that. And I think it gave everybody an opportunity to kind of think about, what is this going to change for you? And I think if I hadn't done the course, that is something that I would never have known. The 5 skills, I think, is really powerful. And I think that was some of the things that I had incorporated into my slides as well. Because it's something that is extremely basic, but also something that we forget when we use communication. And also about the 4 types of anger, right? The 4 phases of anger. I think that really helped me break it down and explain anger, because like we talked about even today's topic, these are not things that we discuss or talk about, and even organizations are not very forthcoming when there is crisis or handling these things through communication. So I think those were some of the takeaways that I've actually written down. So thank you, everybody.
Thank you so much, Michelle. I think it was wonderful briefing by you of your learning. And at the same time, I think it was pleasure having you in the program. We also enjoyed the interaction you had, the questions you had, and the way you kind of, stirred the discussion. I think that's the fun that we had. Thank you so much. Thank you. So who would like to?
May I?
Sure, please.
Hi, I'm Shikha Bhargav, working as Manager Quality and Training, working with the ABAS, Institute of Human Behavior and Life Sciences, is in hospital. And it's a great pleasure to be with such kind of diverse people, where we have hospital administrator, onco-psychologist, and others, even the doctor. And I learned a lot in this session, especially the role plays that I am going to use it in my trainings. And I really appreciate that we are here and we learn a lot. So thank you so much, ma'am, to give such an insightful sessions, and from everyone, I suppose, to bear all such kind of silly questions also from my end. But it's thank you so much for everything. Thank you so much.
Thank you, Shikha, for joining the program. I think you were following up for quite some time to join the program. So finally, you could do it this time. It was pleasure having you, and I think you were asking quite intelligent questions. Don't think that they were silly. No question is silly. If you want to know something, that's a question, and there should be an answer to it. So never ever think that it's a silly question.
It's just because might be some other people will ask me the same kind of questions, and I must having the same answers and how to respond them. Because I'm also trying to be into the training sector. So, and that's why I'm here in this session also and other sessions also. So that's why I'm asking.
Absolutely. Pleasure. Thank you. Thank you. So,
Ma'am, do we have to prepare the feedback, or it's like
no,
I saw
no.
Michelle was preparing.
No. It's all right. You just have to tell whatever you feel
Okay.
about.
Okay, ma'am. Actually, good evening, and I'm Maheshwari from Salem, working as a joint director of my family-run hospital. It's a small hospital with 100 beds. And I thoroughly enjoyed your session, ma'am. Dr. Indu, your delivery in this training was truly impactful for all of us here, because I am not a clinician, but still I was able to put in their shoes and see how their point of views in that matter of treating patients or in admin situations and all. And the way you engaged us, the participants, like the collaborative learning environment you've created, ma'am, like be it in role play scenarios or some sharing your case studies, materials. Everything had given us a deeper understanding on overall about how the patient care can be more effective and how we can be more genuinely committed to improve our patient care in our hospital. And my point of view has changed, because I was initially thinking that only patients are the most important people to be taken care of, but you told me your staffs are also very important. So they are going to represent us to the patient. So in that way, in that clarity was too good for me. In this training program was really excellent standards, ma'am. And thank you so much for giving us this program.
Thank you so much, Maheshwari. Thank you for joining the program and attending the program very regularly, in spite of the fact that you are in a administrative position in your hospital. So I'm sure you must be working, morning 6 to evening 6. But in spite of that, you attended the classes very regularly, and you participated, and you shared your learning and experiences. Thank you once again. So, Arshia or Dr. Pradeep, whoever wishes to speak. Dr.
I'm
Pradeep.
Dr. Pradeep. I'm basically an assistant intensivist, and I was quite reluctant to join this program. Uh, how it will help me, but it has changed the whole scenario in my practice. It has told me what is the importance of communication for understanding the patient expectations, what they want. Because as we have been told that we never gave 80 seconds to the patient for their uh, for their history or when they tell us their complaints, and we usually interrupt them. Then the importance of body language, importance of verbal communication, and rule of 73855, and then pattern of this thing communication, passive aggressive, and then last but not the least, uh, breaking a bad news, how to manage medical error communication to the patient. So it has really helped me a lot, and thanks again to Dr. Aneja and the whole team for such an interactive session. Thank you.
Thank you so much, Dr. Pradeep. It was pleasure having you in the program. I think you also attended all the sessions with great sincerity and dedication. I know the kind of job you do. You must be really, really very tired and exhausted by the end of the day. But you made sure that you participate and you attend these sessions. Thank you for being there. We are very happy to have you. Thank you. So, Arshia, it's you.
I think I will start with I'm really going to miss these sessions. I mean, interacting with everybody here in the group. It has been such a, I think we felt like a family. Everybody was non-judgmental. We could talk very freely. And so that's the first thing I would like to share. Okay, so to introduce myself, I'm Arsha Bhandari. I work in the field of pharmacovigilance, and I'm also a patient safety advocate. I founded an organization called PHV Fit, which works to, create awareness about patient safety principles. And that's the work that I do there. That was one thing that inspired me to take this training. And I reached out to ma'am to understand, how I can be a part of it. Since I am just I'm not a medical professional. I do not work with hospitals. First of all, I was doubtful if this training would really be helpful for me or not. But I think my experience has been, it has been an eye-opening experience. Not only from the perspective of that I came to know the other side of it, because there was a lot of interaction, there were a lot of examples that were shared. And, from my work perspective, I understand if I want to get into really creating some change, it has to, I need to know the complete picture of it and not just a one-sided picture. So I think the content that was shared by ma'am in all the trainings was very, very relevant. The way the content was shared, there were different pedagogies that were used. There were videos that were used. There were, role plays or the different ways, diverse ways that ma'am shared with us, which not only helped me in, because I'm not working in a hospital, but, wherever I'm working, it helped me, as a professional as well. So that's, to give an example, our working styles or, our communication patterns, I was able to recognize, okay, sometimes I am this passive aggressive person. Sometimes I'm this, I'm not as assertive I should be. So it is also, for me, it was also a coaching. But at the same time, I understood that, when we are talking about healthcare communication, the way, ma'am, you've approached the whole training and the whole system of, through the psychology perspective, that doctors are human beings. And if we want to change the whole structure of it, it has to come when we consider ourselves as human beings, or, the whole system as a human. And how, when we work on that, the change is automatically going to come. So these are few of the things. And role play, I would like to share that as well. So I shared it I do go for Buddhist meetings. So I wanted to do something very different. And role plays, I've been learning this in these sessions every day. And I did that in my meeting. Everybody was very happy. And, we could share a very complex concept in a very simple manner with everybody's participation. So it has been a wonderful, wonderful, wonderful experience. I'm really thankful for this opportunity. And I'm thankful to everybody here. It has been beautiful interactions. Thank you. Thank you so much.
Thank you, Arshia, for such a wonderful feedback. I hope this training helps you in doing whatever you want to do in terms of your professional or personal development. The whole idea is that we should be able to become part of the system if we want to change the system. By staying outside, by judging people, by labeling them, we will not be able to empower them with the skills they require to change the system. We are part and parcel of the system, and we have to, work hand in hand with everyone and bring change. We require change. There's no doubt about it. We really need to empower our patients, and you're doing a wonderful job when you talk about patient advocacy. I really wish I had time to get into that, because a lot of time I feel like getting into patient advocacy, because that's where we have to empower the patients to deal with their counseling. But I think each one of us is doing a wonderful job wherever you are, in whatever position you are. Continue doing what you are doing. Use this learning and try to empower others with these skills, because that's how the system will become better, improve. And as and when you need my help, you want to take some guidance, some discussion, I'm just a call away. I don't hesitate calling you back or talking to you. You just have to message me, or if you call, I'm free, I'll take your call. Otherwise, I'll see your missed call and I'll call you back. So I'm just a call away. And I will not be dismantling the group, because I normally do not dismantle, but we normally don't pass on any unnecessary messages. So the group will remain. You can forward anything that you feel that's relevant to you or to the group. We can always share with each other. If you have a question, you can put it to the group. But I do not normally dismantle the group. As of now, I've never dismantled any group, but I've never had any problem also, because we're all professionals, mature, and we don't, pass good morning and good evening and those kind of messages. So thank you very much. It was extremely wonderful to have all of you. And I think sometimes having a small group gives you an opportunity to connect with each one of you individually. I think this is the first batch where we had just 6 or 7 participants. Otherwise, it has been always 15, 18, 20 kind of members. So, of course, I try to interact with each one of the participants, but then smaller group gives you more opportunity to interact one-on-one. So it was extremely a wonderful experience for me to learn from all of you, because it's never one way, it's always two way. So let's stay in touch. And I will be sharing the post-program assessment and also the feedback for the session. So I request all of you to complete it. And then also, Michelle, if you can, create one message with your name, the name that you want on the certificate, so that there is no error. Make sure that everybody can add their name to that document and, repost it. And I will see that within a week's time, all of you get your certificates. So should we close the session? Thank you so much. God bless you.
Thank you so much, ma'am. Thank you, everyone.
Thank
Good
you, ma'am.
night.
Thanks.
Take
Thank
care.
you, everyone.
Thank you.
Thank you, everyone. Bye. Good night.
Pleasure meeting.